Okay, hello everyone, and welcome to Data for Action, the role of data science in public health surveillance, which is the third of the Surveillance Advances seminar series, co-hosted by the Public Health Agency of Canada and the National Collaborating Center for Infectious Diseases, or NCCID. My name is Luisa Arroyave. I'm a postdoctoral fellow at NCCID. I will be your moderator today, along with Louis Horn, who is an acting manager in the Data, Surveillance, and Foresight branch of the Public Health Agency of Canada. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning programs and policies related to infectious diseases. And we are incredibly pleased to be co-hosting this series with the agency. I would like to acknowledge that NCCID is hosted by the University of Manitoba on the original lands of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and on the homeland of the Métis Nation. At NCCID, we strive to honor the lands and their original caretakers in our work. We acknowledge that we are on Treaty 1 land. We recognize that these and other treaties have been implemented as part of the process of colonization intended to benefit some while harming others. We are committed to working with our partners towards reconciliation. Okay, before we dive into today's seminar, there are a few housekeeping items I would like to mention. A recording of this seminar and presentation slides will be available shortly after the seminar at the NCCID website, which is nccid.ca under webcasts. The chatbot for participants has been disabled for this session. The host will be using the chat box to communicate additional information with participants. If you have technical problems with Zoom during this seminar, please email us at nccid@umanitoba.ca. Also, please send us topic-related questions through the Q&A tab, and we will try to address as many as possible in the discussion period after the presentation. And also, you can like any of the questions to push them up in priority. We would also like to know that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Experience for Professional Development Hours for members of the Canadian Institute for Public Health Inspectors. If you require a letter of participation, please look out for the survey that we will share after the seminar. Over to you, Luis.
Good morning and good afternoon, everyone. And thank you, Louisa, for covering some key housekeeping items. Welcome, everyone, to the third seminar of Surveillance Advances. Bienvenue à tous. Well, today's seminar will be delivered in English. We welcome everyone to pose their question in their language of work. I would like to begin by acknowledging that I live and work and play in the dish with one spoon territory. The dish with one spoon is a treaty between the Anishinaabe, Mississaugas, and the Haudenosaunee people that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. I would like to begin by acknowledging that the land on which I gather and join you today is the traditional territories of the Wendat, the Anishinaabe, the Haudenosaunee, the Métis, and the Mississaugas, credit of the First Nations. Today, we will have participants and presenters joining us from coast to coast to coast. The land in which they and you join us from represent the lived experiences of many Indigenous peoples, all with their own unique health story. I would like to acknowledge that the practice of public health surveillance may raise concerns for Indigenous peoples and other communities. To public health professionals, surveillance sounds similar to epidemiology, which is about understanding the distribution and patterns of determinants of health and diseases in specific populations. But for others, surveillance may carry negative connotations about security, privacy, and control. For this seminar series, we would like to note that we use the word surveillance to refer to the assessment of and response to public health threats as a core function of our public health system. This seminar series is not just about the speakers, the organizers. It's about you, the audience. Active participation, questions, and perspectives are vital to the success of this initiative. We encourage you to engage in the discussion, ask questions, share your thoughts, and foster collaboration that can lead to improvements in public health surveillance.
Okay, with excitement, I would like to introduce and welcome our speakers for today's seminar. Our first speaker is Dr. Jude Kong. He's a professor at York University, renowned for his expertise in artificial intelligence, data science, and clinical public health modeling. He serves as the founding executive director of two significant initiatives, the Africa-Canada Artificial Intelligence and Data Innovation Consortium and the Global South Artificial Intelligence for Pandemic and Epidemic Preparedness and Response Network. Our second speaker for today is Dr. Nathaniel Osgood. Dr. Osgood is a professor in the Department of Computer Science at the University of Saskatchewan, where he directs the Computational Epidemiology and Public Health Informatics Laboratory. His research focuses on combining tools from system science, data science, computational science, and applied mathematics to inform decision-making in health and healthcare. He is also the co-creator of diverse epidemiological surveillance and data collection systems, most notably the Google Android, iPhone, and web-based Avicenna research platform applied in hundreds of health-related studies around the world, including COVID-19 related studies. Welcome, Dr. Kong and Dr. Osgood. We are happy to having you today, and we are excited to learn from you. By the end of the seminar, we hope that all of you here today will be able to understand how artificial intelligence, data science, and mathematical solutions can be used responsibly to improve public health surveillance and response to emerging and re-emerging infectious disease outbreaks. Also understand the feasibility and benefits of using artificial intelligence to enable real-time updates of transmission modeling with diverse upcoming data streams. Also highlight the accuracy benefits secured by incorporating wastewater data sources among the real data sets used to ground models. And finally, note the likely value of jointly updating models of multiple pathogens, sharing with risk factors with cross-pathogen surveillance data. And now I would like to invite our first speaker, Dr. Kong, to share his experience and knowledge in artificial intelligence in public health surveillance. Thank you, Dr. Kong, and the floor is yours.
Thank you very much, Lisa, and thank you for the opportunity to share the work that my team has been doing with the public. I will be talking about a disease outbreak detection and response tool supported by artificial intelligence and multi-source real data collection platform. Could you move to the next slide, please? So, like mentioned, I'm the executive director of the AI4PEP, and so we have a lot of projects helping governments strengthen healthcare system across the entire global south. But today, I will talk about the platform that we are developing here in Canada. Next slide, please. So with that, I want to acknowledge the IDRC for supporting this work that we are doing across the entire global south. Next slide, please. So the platform that we are developing, which I called Auto Epidemics, which will be real-time, updating real-time, taking into account, first we have a data portal, and that data portal contains data from various sources: ambulatory care, animal data, patients' interactions, community health data, hospital testing, viral sequencing, mobility testing, all conventional data you may think of, and then unconventional data like wastewater management data that Professor Osgood will talk about today, Google News, Street View images, wiki trends, financial data, social media data, over-the-counter drug used, satellite data, and pharmaceutical visits. So we'll collect all this data into a data portal for other researchers to use. And at the same time, we then build models. So we'll have another platform that's linked to this called the Auto Analytic Engine. The Auto Analytic Engine contains artificial intelligence models that have been trained and mathematical models for human behavior and different issues. As a policymaker, you don't need to know what is happening in the back end. You come, you choose a region, you choose a type of model, then it's able to use the data we have. And if you choose to substitute the data with another particular one, you will substitute that data, and then it will fit the model that you have and update and provide you different scenario analysis like hotspots, earlier warning systems, vaccination strategies, public health measures, and you'll be able to visualize this on the dashboard. So that's a big dream, and that's where we're heading to. And we have made a lot of progress towards this direction. And today, I will be sharing that progress with you. Next slide, please. The next slide, please. So to start with, I will start with the data infrastructure. That's the first part of the work. Then I will move on to talk about the auto-analytic model in the second part of the work, the framework. And then in the last part, I'll present some use cases where I will talk about the performance of our model on Lyme disease, influenza, and COVID-19. So I'll be able to show preliminary work. For the sake of time, I will not present all the diseases that we have modeled this on and all the data we have. Next slide, please. So starting with the data infrastructure that we are building. We are currently tapping into, as you saw earlier on, all unconventional and conventional data. I'll spend a lot of time here showing you the various unconventional data and how these unconventional data correlate with the different diseases. Here, you have Google Trends, which is a great source of data, actually, where what people search, the keyword people use in different regions within the country or different communities. And if you look at, on this other side here, I just plotted the keywords of COVID-19 up to today and the number of Google searches. And you realize here that there's some sort of correlations with the peak. And most of the time, even the Google trend peaked before the real cases. You realize that this is over Alberta, British Columbia, Manitoba, Quebec, and Saskatchewan, all through this, and you realize that there's correlation between the Google trends. If you move the next slide, please. When you move to the next one here, we use the number of Google searches. This is on influenza. Here I show COVID. This is on influenza, mapping almost the same way. If you look at COVID and you look on influenza, what that means is that in the absence of data, this could be used as one of the data to inform this. The peak before that, and it matches clearly with the number of cases. Next slide, please. Now, in addition to just the Google trend, what we equally look at is the rate of searches and the concavity, whether it's concave downward, the second derivative, or concave upward, whether cases are picking up or slowing down, coming down. So we pick that in our model in order to fit the particular model to inform, to alert when a re-emerging disease will occur. Next slide, please. So if you look at this, you get the concavity. Next slide, please. Then, this is a plot of, on the y-axis here, you have the COVID cases. On the x, if you look at this other red one here, is the first derivative of the rate of searching. And you realize that there's some sort of correlation between that and the number of cases for COVID-19. Same here, you look at the first derivative. And then if you look at here, you have the second derivative, which is the concavity, whether cases are slowing down or slowing upward. If you realize here, there's some sort of relationship here with the cases here, when the cases peak. Next slide, please. Then another parameter that we equally keep on looking at, if you look at Alberta here, you find out here the number of, when we go to communities, we either take Twitter data. Twitter is no longer available right now. Currently, right now, we are using Reddit, which is community-based, and this is applicable to each particular community. And if you look at this is the Reddit for Alberta as a whole, but we do this for particular communities. This is Alberta, this is Ontario, and this is Quebec. And you realize that there's correlation between that and the number of cases. So we equally get that data. Next slide, please. And the wiki trend, which is searching for the particular keyword within COVID, here, I just plotted here to show the correlation on that data that we extract and put on the platform. And when you look at these, if we plot the wiki trend from 2020 up to now, you see a correlation between that and when COVID peaked at different time points. Next slide, please. Then the news, where Google gather all the news that's available from different regions on different issues that are mentioned. And gathering all those news in real time is one source of the data that we are using. And I just show here another plot that shows the number of Google News items for a particular keyword relating to COVID-19 and COVID-19. And we're doing this for all the diseases, influenza, RSV, and tick-borne diseases. So we're doing that for all the diseases across the country to gather these different data sources. Next slide, please. And satellite data is another data source. Again, we're tapping into all the data sources that are indicated. We are creating a platform to make this data publicly available for everyone to be able to use. And when you look at climatic data, you can take the annual temperature, annual rainfall, asymptoticity, diurnal range temperature, all the data that you may need from the select data, you can tap into that data, or you can take surface temperature and get into that data and use that to inform models. Next slide, please. If you look at here, another source of weather data, you can get NO2 data, carbon monoxide data, CO3 and O1 from there, or methane data from satellite data, and then use that to build your model that will be able to see how those correlate. Can you move to the next slide? Let's see how they correlate with the different diseases. If you look at here, this is SO2, and look at how they correlate with COVID-19. Again, there's much more that with flu and other diseases. If you look at a CO2 with COVID-19, you see some sort of correlation between these. And you look at influenza and this, you see some sort of a correlation between those air quality and these diseases. So we tap into this again. We first of all studied and look at a correlation before we pick each variable and add to our data portal for other researchers to use. And then we use that in real time to inform a particular model that will update in real time. Next slide, please. If you look at here, this is the mean temperature, and you look at here, this is influenza and mean temperature across the year. This is the mean temperature here, and then same here with influenza. You realize that there's some sort of correlation with the data and the number of cases. Next slide, please. Once we have gathered all the data, in the second part now, we target mainly on the model framework, which is building on the model. Now, I will not be able to show you all the model that exists here, but as policymaker, you don't need, I call it auto-analytic engine because the models are at the back end. And as policymaker, you come there, you just have a user interface, and then you type whichever region, and then you're able to pick the model you want to use. We have both mathematical models and artificial intelligence models here informing policies. Here, I will show you the framework that we have used for an earlier warning alert and response system. Next slide, please. One of the data that came into this year is community engagement. Can you go up to the other slide? Yeah, thank you. The community engagement piece, which is very vital, data from community health centers. I've got a lot of questions on how do you do community engagement, and the case of the Black Creek Community Center, which is found in Jane and Finch community, Northeast Toronto here, is very, very, very a case for us I feel that could be copied. Again, there are other models within the country, but I really love this particular one. Cheryl is the director, the executive director of the center. This is Cheryl here. Every 2 weeks, she has community ambassadors that move from door to door collecting data, and then brings it and she adds it to her community health data. Every 2 weeks, they meet with university professors like myself, researchers working on this as tools, and then they inform what models can be built. And we build that platform so that they own their data, community data, and you build the models for them to use. So that's one particular area of data that we use for these particular cases. So I thought I should share this. Next slide, please. Yeah, so for our model framework, the first is we get the historical data, all the data that we have seen correlate to different diseases when we're working on a particular disease. Once you get all this data, you pre-process it or you process it, then the next thing that we do is that we use a graphical neural network in order to build connection between the various provinces or the various communities. Why? Because there's interaction between these communities. Once you build graphs between the communities and give weight to the different variables you're getting from one community. So the way the GNN work is when you start initially, each node only know what is happening within its surface. So you consider if you consider each province here or each province as a node, then at the start, Ontario only knows what is happening in Ontario, and maybe Manitoba knows what is happening in Manitoba. Then within the next time, adjacent nodes will transfer information to the next node after you have given weight, and so on. By so doing, you're able to get data from one province to another. You run it till the nodes get information from each other. Once they get the information, then we pass it to a CNN, convolutional neural network. The reason why we have a CNN at the base here is because we realize that when we put that, improve the result. So you train a CNN here, and then we pass it to a GRU, which is you can think of it as a recurrent neural network with getting a recurrent neural network. So it just came to existence in 2014, similar to LSTM, but in this way it's gated, so you don't particularly consider all the variables. Then we pass it here, and then we're able to project the number of cases. We train this hyperparameter optimization to decide how many layers to consider for the recurrent neural network, and then we're able to project a certain number of time. Currently, right now, we're able to predict up to 30 days ahead of time with the models that we have for different diseases, and then you focus on the dashboard. So there are 3 layers into this training where we first of all build the graphical neural network. After building the graph, we pass it through the convolutional neural network, then train an RNN, and then use the RNN to forecast the cases that will happen. And then at this point now, we can integrate the mathematical modeling for different human behavioral dynamics when we already have the forecast. Next slide, please. So I will now present some of the results that we have so far. Next slide, please. So I'll start with COVID-19. If you look at this, this is the framework that I just presented to you. The mathematical models that we have, they're looking at different behavior, taking into account this data is not there, but I just want to present to you how this system is working very well. This is not the training set, this is the testing set. And this is the focus here for COVID-19. And it worked effectively across the provinces. And again, across regions, we did this across communities. Within the Jane and Finch community where I work, I don't work in all communities across the country. I currently work with the Jane and Finch community, and we did this for the community data portal that we have. Next slide, please. This is the case for influenza, and you realize that it captures the data pretty much across the entire country. Again, not just in the country here, I did it for Africa as well, within what we did, and it captures very well the monitoring here. Next slide, please. And here, if you look at this is for tick-borne diseases, where we equally take into account select data and all those data. We didn't have Lyme disease itself, but we use number of ticks. If anybody have Lyme disease, please will be able to test with this. We use number of ticks. And it's able to match pretty well the number of ticks across the various provinces. I'm just presenting the case of Ontario and British Columbia here, and it matches pretty well. Again, this is 14 days ahead of time. When I say 14 steps, it's 14 days ahead of time. And this is the testing, not the training set. And we did this, and it's able to predict up to 40 days ahead of 30 days ahead of time up to now. Next slide, please. So while we are doing all of these, I equally said that as we are building these tools that are proactive, it is very important to learn from historical colonialism to ensure that data colonialism doesn't take place. In the sense that if you look at the similarities, appropriation of natural resources with historical colonialism is the same with current day data colonialism, appropriation or quantification of human life through datification. So we need to ensure that we do everything responsibly. If you look at expropriation of land and resources and bodies, which happened in historical colonialism, is the same thing nowadays, where we are just there to be discovered, as capital to be discovered and exploited. You have Internet of a Thing just exploiting data from human beings. You look at exploitation through industrial capitalism. You have exploitation through AI capitalism. So all of this exists, and it's necessary, next slide please, that we have a framework like this where it's very responsible AI. You ensure that it's locally relevant and informed by the community in question. By locally relevant, it's autonomous, caring, connecting, decolonized, human and community-centered, inclusive, intentional, intersectional, just, practical, protecting, process-based, and sustainable. You ensure that it's responsible and ethical for policies and regulations, whatever this means in your own context, but responsible, accountable, auditable, compliant, ethical, respectful, safe, and secure. And you ensure that it's explainable to the whole society at large, equitable, fair, interpretable, reliable, reproducible, transparent, trustworthy, and unbiased before you go on to collect the data and build this system. Next slide, please. I really want to thank my team that have worked on this, building this framework. Very soon it will be live, updating in real time, in particular my postdoc, Dr. Zara Ni, who is leading the team that's working on this. Next slide, please. I really want to thank my founder, NSEC, IDRC, CEDA, and the New Frontiers in Research, and York University. Next slide, please. In conclusion, I want to say that these type of system, like AI epidemics that we have, are very, very necessary for controlling and containing infectious diseases. Systems that tap into unconventional data because they will take into account the communities that have been deprived or do not feel comfortable going to the formal clinic or formal health system. So tapping into unconventional data and machine learning with the advance can be very, very instrumental if used responsibly. And so policymakers can be able to even use it without knowing what is happening on the background. So such a system is very, very, very instrumental. Next slide, please. Thank you very much, and merci beaucoup à tous.
Thank you so much, Dr. Kant, for your presentation. And now we would like to invite our second speaker, Dr. Osgood, to share his experience incorporating modeling into real-time surveillance. Thank you, Dr. Osgood, and the floor is yours.
Thanks so much, and it's a great honor to be with you today to share with you some of the approaches that we've used through the pandemic to provide daily or somewhat coarser-grained reporting to 17 jurisdictions by combining AI with dynamic modeling to provide real-time epidemiology, acute care demand, and capacity utilization monitoring, nowcasting, and forecasting. Before I begin, I need to acknowledge that I'm speaking from, I live and work in Treaty 6 territory, the homeland of the Métis and the Cree Nation. And I pay my respects to Indigenous peoples of this place, past and present, and reaffirm our relationship with one another. Next slide, please. So the motivation for this work lies in a couple different areas. One of the most basic is something that we all struggled with, and decision makers particularly struggled with through the pandemic. But it's emblematic of broader changes. And that is, even for a particular pathogen, to really understand what's going on, we're often confronted with diverse time series, each with their own trajectory, but all whispering to us of some underlying situation that we need to understand, all being facets of that underlying situation that is telling us something about the current context and where it's likely to go, if we can only listen carefully enough. Next slide. Now, within recent years, and drawing on threads that we were exploring before the pandemic, there's been an enormous growth in the interest in and use of wastewater epidemiology. Epidemiology to help us understand, for the infectious disease context, the viral or variously bacteriological shedding going on within a population, whether at a facility level, municipal level, or sub-municipality level, giving us some understanding, next slide, although through very noisy time series, about some understanding of the burden of illness within that population as manifested by shedding into the wastewater, in a way that has some big limitations in terms of noisy data, but does capture some elements of health burden being inflicted on groups that, due to stigma, due to trust concerns, due to access issues, are underserved by testing efforts. Next slide, please. Now, within this mix, and juxtaposed on the previous, we of course saw during the pandemic greater and greater prominence accorded to transmission models. Now, these models come in many forms, many shapes and sizes. Some of our group's biggest emphases are in individual level modeling together with community members in key issues. But others of them are at a compartmental level, such as the model shown here. Regardless of their particular shape, these models are used to incorporate some theory about the underlying situation and drivers for it and how it might evolve over time. So, for example, they'll incorporate some theory regarding the natural history of infection or transmission routes. They might capture over on the left-hand side there the impacts of interventions such as vaccination, or a bit further up, the impacts of non-pharmaceutical interventions in reducing transmission, or intervention strategies such as contact tracing and mass testing. But they do so by depicting kind of an underlying theory of the pathogens involved and the ways in which, the characteristic ways in which the current situation drives its evolution, with people recovering, new people developing symptoms who were previously latently infected, etc. Next slide, please. Now, these models offer, and during the pandemic, from the early part through succeeding months, offered fantastic levels of insight into thinking through the ways in which we might intervene to better wrestle this beast of COVID-19 to the ground, the ways in which vaccination strategies, contact tracing efforts, et cetera, might allow us to bend that curve. But they have their big limitations. And, unassisted, all models, it's in the nature of models to diverge from the empirical situation for many good reasons. Inevitably, they involve simplifications and omissions. Other factors change, behavior changes, availability of therapeutics change, or availability of PPE. But also when you're dealing with a low incidence environment and trying to understand when an outbreak might really gather steam, even stochastic events, happenstance, can have a really big impact on that epi curve that we look at every day, in which during my secondment for a year to year and a half into the health system was a central focus of our discussion with many stakeholders. And this divergence is important because when it comes to modeling, it can really impact the trade-offs that we ascribe to different interventions. And if we're very unsure about the underlying situation, it can limit the accuracy of our reporting of those trade-offs from our modeling. And a point that's often missed is that merely adjusting the parameters of the model gets us a certain distance, but really falls well short of what we need to reliably align an understanding of the model, the current situation now with where it might go through the model lens, and also can mislead us in terms of our assessments of how much surge capacity mobilization would help, or how much increasing our contact tracing might aid it, or how much ramping up vaccination to beat out the new incoming variant might offer benefit. Next slide, please. So the strategies that we've been employing, I have such gratitude to Jude, not only for the wonderful role he plays in leadership in this country, but also for his preceding talk, because it meant that I could write atop some of the basics which he emphasized. And within this talk, we're going to be talking about a similar vision, but which places dynamic models, these models capturing theory, often theory honed through a great deal of clinical expertise and epidemiological observation captured in a model, turning them from discrete products into always updated services. And the idea here is to provide, on a daily basis, an evolving integrated picture of the underlying epidemiology of the situation that leverages a transmission model that captures the natural history of infection, transmission, as best we understand it, but brings to that AI techniques in the form of Bayesian computational statistics tools, which combine that with diverse incoming data sources of the sort that Jude spoke about being offered through his growing platform, and that were increasingly available during the pandemic. And by so doing, it allows us to track and spot changes in behavior, to make sure that our understanding accords with measures for what we accord with what's measured from the population, but also allows us to estimate things which aren't directly observed, things like number of undiagnosed cases, or things such as the force of infection, et cetera. Now, when we undertake this commitment to keeping our models constantly updated with data from these very diverse time series, as that we can layer in over time, we can moreover project forward, having with confidence understood the current situation probabilistically, and we can evaluate what if scenarios that might involve adaptive policy response. Next slide, please. So, the sort of common exemplar that I think we can compare this to, or metaphor to which we can look towards, one we're all familiar with at some level. weather models have come advanced by leaps and bounds over recent decades. They're extraordinarily sophisticated beasts. But we would all recognize that never more here than in the prairies, it would be a fool's errand to rely upon the estimates for tomorrow's weather from a weather model whose latest update with data was the beginning of the month. With weather models, the most sophisticated of them, we secure enormous value precisely because we not only have a rich, sophisticated model, but it's constantly refreshed with data about what has actually taken place to capture the vagaries of the shifting patterns on the weather fronts of the low pressure systems, et cetera. So we keep our models in this framework updated with the latest evidence through diverse data sources that each provide a different facet of the underlying situation as depicted by models. So next slide, please. And I'm going to highlight a few points here, but I want to, before that, I'm going to come back to this. If you could go forward one slide here, Jonathan, and I want to emphasize that these models learn over time. As using a machine learning algorithm, they observe these varied time series. We've worked quite a lot, like Jude, with data from online behavior, such as search volumes and social media posts. Wastewater data was central for a lot of our reporting and forms a centerpiece of it in other areas, such as toxicovigilance. But also data from public health and from acute care utilization and demand and admissions, census, et cetera. And from this data observed till now, we get a certain picture. The machine learning learns a certain understanding of the situation, but it learns it aligned with model structure and then uses it to project forward. So if I could go back one slide. These aren't curve-fitting models. Instead, they're really taking these diverse lines of data, some of which I alluded to there, and asking, what is it telling us about the underlying situation? What is it telling us when we view it through the lens of our understanding of the natural history of infection? And to do this, we use AI techniques in the form of Bayesian techniques that give a probabilistic understanding to the situation. And we align that understanding with new data when it comes in that sharpens our picture of what's going on probabilistically. And so when we project forward, it's not projecting a curve forward, it's projecting from an understanding of the current system state and capturing the momentum of the situation going forward. If we could go 2 slides forward, Jonathan, that'll be so good. So underlying all this is a model. And what this really gives is, and I know it can be hard to imagine, but it's a probability distribution over a system like this that gives some sense about how many people are likely in one undiagnosed state or another. How many people are likely latently infected, just not showing symptoms? How many people might be infected, but in an oligosymptomatic, post-symptomatic, or outright asymptomatic fashion, and allows us to track this through probabilistically. With each new tranche of data, say daily, we update it whenever it comes in. Next slide, please. So the uses of this system are varied. One of the most basic uses is it gives you almost a 3D picture, similar to what a CAT scan or an MRI scan might give of the human body, a sort of tomographic picture of what's going on right now in the underlying population situation, this nowcasting. If we could go forward one slide, and I'll come back to this. This involves making sure that the model understanding compares favorably against observed data. The model distribution, remember it's probabilistic, is shown there in green, and it's matching these types of data. And some of this might be on, for example, case data. Another one, next slide, please, might be for wastewater data. And typically we'll have these for dozens of these different types of measures. Some episodic, some irregular, some available daily, et cetera. But what it gives you as a generative AI algorithm is shown in the next slide. So if we could go to that, it as a generative AI tool, what it's doing by matching this up in the context of the model is giving picture tomographically of what's going on in areas of the system where you don't have data, but where the situation is in some sense implied by the logic of the model and the logic of what data you have. So, for example, estimating undiagnosed infectives or, oligosymptomatic individuals, et cetera. Now, beyond just this tomographic picture of the population, we can also use this to project forward, and it captures this generative understanding in so doing. We could use it to backcast to understand why we didn't get that intervention response we expected last month, in light of hindsight from later data and from the picture of what must have been going on at that time implied by the model and that data. And we can use it to ask about policy impacts. Next slide, if I could. So the advantage of this is this unified, integrated, system-wide picture consistent with the natural history of infection, this ability to layer in new data sources of diverse sorts, and to estimate not only parameters of models, but the underlying situation, what we call latent state in technical terms. It's highly tolerant for missing data. There's no assumption that all data is available regularly. And so when data comes in, catch as catch can, we can easily place it in the model. But one of the most exciting elements, an element that we didn't explore fully in the early stages of the pandemic, but is central to our strategy now, is the fact that if we pursue this strategy with multiple pathogens at the same time, we get a whole greater than the sum of the parts. If we have data from RSV, from COVID-19, and from influenza, all of which have some common drivers for them, some common risk factors, have mixing patterns that are shared by all. By bringing in those together, we can sharpen our ability to predict any one of them, because we can estimate, for example, the mixing of the population much better. We can estimate the underlying behavioral changes far better. And it gives an accelerating effect to anticipate any one of them. Getting wastewater data for influenza tells us about where COVID-19 is going, et cetera, in a way that's very rich. Next slide, and I'm going to have to finish up here. The frameworks that we've built here are extensive. They leverage the latest computer science techniques, being a computer scientist myself, with parallel and distributed computation and sophisticated scripting frameworks, et cetera, together with techniques for automated analysis using these techniques. Particle MCMC is our workhorse tool these days, and taking in data from diverse jurisdictions and having custom reporting targeted to different types of individuals within different jurisdictions to provide them the data that they specifically need in a fashion that's quite automated. So next slide, please. So the conclusions here. Models, while of great value in capturing reasoning, give much additional value if they're used for service provision on an ongoing basis, and if they're updated daily. Combining AI and Bayesian techniques with dynamic models allows for these always updated models. And it's synergistic with the sort of large-scale, high-velocity data that we're increasingly getting and that Jude spoke of so eloquently. We can perform this at different levels, national, regional, local, and we've done so extensively. And they can bring in novel data sources with varying quality, with excellent effect in sort of helping us anticipate future trends. Even a lower quality data source like social media mentions, brought together with clinical data, can give us much better ability to predict forward clinical data than just clinical data by itself. And with appropriate reporting pipelines and infrastructures, we can really build up largely automated systems. When I say largely, I mean sometimes there's a manual process for security reasons for getting the data that can automatically ingest data, update our models, give reporting, and allow interactive exploration of it. And we are looking at a new era where we believe the whole is greater than the sum of the parts, where pursuing this on a multi-pathogen basis can give us much greater insights than what we get for each pathogen in isolation. Thank you so much, and I look forward to the questions.
Great. Thank you so much, Dr. Osgood and Dr. Kong, for a very detailed presentation on some very important topics around data surveillance as well as public health surveillance. So without further ado, we have some great questions already posed in the Q&A chat portal, I will say. I'm going to start with the first question, and I'm going to actually ask this question to Dr. Kong, but Dr. Osgood, feel free to comment as well. The first question is around the new legislation in Canada with regards to BC 18 that affects search and news products, and Google removing links to Canadian news because they decide to not participate. Or are there other strategies that the model can look at in terms of connecting with and collecting news in Canada from other sources other than Google? Dr. Kong.
Thank you. Currently, right now, what I know is, and I did it as of yesterday, you are still able to use Google News and be able to get the data. I don't know whether the bill is already in effect or not, but I'm still able to do it. I worked on it yesterday. So if that gets out, people will always find a way or other API to use. At the moment, I have not thought of any, because the way to get the news, local news on other newspapers, Google is able to bring that together, and that has been very, very vital. I hope that doesn't change. I hope the bill doesn't affect it. I know that affects social media, but it shouldn't affect Google News, because there's much to get when you get different news from different communities when you're surveying diseases.
Great. Thank you so much, Dr. Kong. And for participants who aren't familiar with Bill C-18, C-18 requires big tech companies to compensate media organizations if they want to continue to host Canadian news content on their platforms. Just for overall awareness for members on this call. The next question I think I'm going to pose to Dr. Osgood. What public health actions to prevent and control health events have resulted from forecasting?
Yeah, it's a good question. And I want to emphasize that most of our work took place in a combination of these techniques with other sources of advice given for these jurisdictions. One of them.
Oh, Dr. Osgood, you've muted yourself.
Oh, I'm sorry. Yes. So I'm not sure how much you heard of that, but fundamentally, these techniques were used alongside additional sources of advice, and commonly packaged together with source of advice. So when we're talking about these many jurisdictions that we worked with, often our reporting was combined with additional lines of projection and understanding in shaping in order to inform decision making. And in some jurisdictions, such as those that Denise, I had the pleasure of working with Denise here in Saskatchewan, those were there were separate reports carried out on a daily basis with effective reproductive number estimates, as well as force of infection estimates in undiagnosed individuals that played, a central role in the discussions with the chief medical officer here in Saskatchewan. This reporting certainly played a key role in the discussions that took place at the community level in some of our northern outbreak analysis with what was initially an outbreak in La Loche, and informed discussion about where the effective reproductive number, as well as the underlying epidemiological situation, was going there. And collectively, it's hard to be absolutely sure was it only this line of evidence or one of the other juxtaposed ones, that there were, in the first year of the pandemic, a number of responses to the changing epidemiological situation that were informed by these numbers and the estimates coming out. I think in the Delta, the Delta phase, we also had estimates that were being reported daily there, and were consistent with the picture that was informing a growing crisis, consistent with our other reporting here in Saskatchewan concerning, the need to act early and swiftly to avoid overrunning our hospitals. That didn't always happen. To I might add, very deleterious effects, including having to fly patients to Ontario. So certainly within the public health milieu, these informed a lot of the discussions. Decisions were made in some cases along the lines of what seemed aligned with the results that we were getting. In other cases, the decisions were not made, but there were adverse effects that were similar to what was being anticipated by the modeling. So it was certainly an important factor in a lot of the discussions that I believe was one of contributing factors in shaping those decisions. So I'll leave my comments there.
Thank you so much, Dr. Osgood. The next question that I'm going to pose will be for both of you, and it speaks to data sources, but also partnerships and relationships with other key actors within the public health system. So Dr. Kong, in the work that you've done around wastewater surveillance, did you work with, for example, the National Microbiology Laboratory in Canada, and also Dr. Osgood, along the same lines of wastewater surveillance, did you use data from the Health Infobase website, the Public Health Infobase website, in some of the work that you've done to date?
Thank you. I could go with that. I haven't worked with the National Microbiology Lab, and please, you are really welcome. I need as much data to build this platform for earlier alert, warning, and response system that updates itself in real time. And so having your data will be very, very vital. Most of the time, I have used publicly available data because I got all of that available. Any data that the Public Health Agency of Canada make publicly available, I've tapped into all those data for the conventional data. And I make good use of unconventional data, as well as community health centers within the communities across Canada I work with. I pay a lot of attention into data that do not get into the formal system. What about people that do not go to the hospital? So I ensure that that data become very, very relevant in what I do. So in addition to unconventional data that I use, I do really care a lot about the data that community health centers, community centers have in place that are surveying, because that's very, very vital. And a lot of issues do not occur because of the data that of people that go to the formal hospital system, but because of the unconventional data, people that do not go to the formal system. And so I ensure that I pay a lot of attention to that. But I am really making an appeal, because in order for us to ensure that the various outbreaks, re-emerging or emerging ones that have occurred throughout do not occur again, we need all sort of data. We need type unconventional data. We need a visit to community health centers, as well as this type of data. So I'm opening up for anybody that could link me up to anyone that have the data to join our team in building these AI epidemics that will be auto for anybody who doesn't have any idea about artificial intelligence or mathematical modeling to be able to use this and inform policies. Thank you. I'll pass it to my colleague and my mentor. That's good.
Yeah, thanks. I want to mirror some of the things that Jude had indicated. I think some of the most valuable data we found has been collected at a local level, sometimes by civil society organizations relevant to our work, sometimes by local health parties, and not necessarily reported up even to the provincial level, much less the federal level. I have had the great pleasure of working with a variety of labs around the country, and some of those wastewater analyses that we've worked with have been conducted with by provincial partners. And I particularly want to do a shout out to our toxicology center here in Saskatchewan, as well as the folks with Dr. Pung's lab in Alberta that have provided cross pathogen analyses for 18 wastewater plants within Alberta. But we've also had ongoing contact with NML, and NML's growing role within the wastewater front has been, I think, key in the broader use of wastewater across Canada, and in standardizing some of the processes. And so I'm a big fan of their efforts in that regard. Quite a bit of our wastewater data also occurs in the toxicovigilance area, which is outside the scope of this immediate presentation, but where Health Canada is also plays a central role in wastewater management. And I think both national actors, provincial actors, and local actors all play a role. And all of them contribute to a picture. And again, I want to remind us that models here are not just crystal balls to predict the future successfully or not. Most importantly, they're thinking tools. They're tools for helping us understand the situation and often dialogue about it, either in policy dialogues or with local actors. And like Jude, we're very much committed to this idea of no AI about us, without us type of strategy, where we can use these data sources locally or provincially to have those key dialogues with parties at these different levels, all of which are very important.
Great. Thank you so much, Dr. Osgood and Dr. Kong. And I think that's a very good note to kind of end on, which is no AI about us, without us. Thank you both for a very thought-provoking conversation, and I look forward to this conversation continuing off of this seminar series. And on that note, I'm going to pass it back to Louisa to wrap things up.
Okay. We are nearing the end of today's seminar, and we would like to take this time to thank our speakers for sharing their insights and expertise. Thank you, Dr. Osgood, and thank you, Dr. Jude. And of course, thank you all of you for joining us today for the third seminar of the surveillance advances, and we hope you enjoyed the seminar. And please take some time to complete our survey for this presentation. You can scan the QR code on this slide to access the survey, or look for the link in an email that we will share shortly. Your feedback is very important to help us to identify any areas of success and improvement for this series. So also you will be able to request a letter of participation at the end of the survey. A reminder that the recording for today's seminar and the presentation material will be accessible for viewing on NCCID's website in a few weeks. And if you have more questions about the surveillance advances, please visit NCCID's website. There will be no seminar in December. Our next seminar will be held on Tuesday, January 30 in 2024. And that concludes today's seminar. Thank you so much, all of you, for joining, and happy holidays, and see you in January. Thanks.